from the Memorial Sloan Kettering Cancer Center.
Good afternoon, ladies and gentlemen. Thank you for the opportunity to speak. Today I'm going to talk about, as I said, flexible CO2 laser and submucosal gel injection for safe endoscopic and laparoscopic surgery of the intestines. The CO2 laser was originally discovered by Dr. Kumar Patel in 1963, and for this he was actually later awarded the National Medal of Science. Relative to other lasers, the CO2 laser has a long wavelength of 10.6 micrometers and lies in the mid-infrared region. And it is this long wavelength that historically limited the CO2 laser to line-of-sight delivery with a rigid arm. And this issue of line-of-sight delivery also precluded its use in minimally invasive surgery. Recent developments have allowed the CO2 laser to be delivered through a flexible fiber. Under scanning electron microscope, we can see that the fiber is made of a hollow core surrounded by alternating layers of glass and polymer. So essentially you have a rolled up mirror that transmits the laser beam down the flexible fiber. So the first advantage of this flexible fiber is that it fits into endoscopic and laparoscopic ports, and it can be used in minimally invasive surgery and reach areas that previously were not accessible. Another advantage of the CO2 laser is that it is very precise. When you compare it to the YAG laser, it has a very shallow depth of penetration as well as very little collateral thermal injury. And this is in the scale of micrometers as opposed to millimeters. And because of this precision, it is used for very delicate surgery, for example, in head and neck surgery as well as in neurosurgery. The next advantage and strength is that the CO2 laser is efficiently absorbed by water. Based on this property, we believe that there's a potential of using a water-based material as a protective barrier. You put in a water-based barrier and the CO2 laser cannot transmit through, and in this way you can protect the layer of tissue underneath the barrier. So the next step would be to bring this flexible CO2 laser to GI surgery. It has already been demonstrated in the porcine model to be able to perform esophageal ablation as well as gastric cutting and mucosectomy. And we believe there are other potential clinical applications in humans from Barrett's esophagus to villus adenomas. Our hypothesis is the flexible CO2 laser may be a valuable surgical tool for the intestines in endoscopy and laparoscopy, and pre-treatment with a water-based gel can protect the intestines from perforation. The specific aims are to evaluate the efficacy of the flexible CO2 laser in burning through the intestinal wall, to assess the susceptibility of intestines to perforation after mucosal dissection with the flexible CO2 laser, and to determine if pre-treatment with a water-based gel offers any protection. So in the first part, we did a spot ablation. We pointed the CO2 laser at the intestines until transmural perforation occurred. We did this at different powers, as well as with and without pre-treatment with gel. In our setup, we laid the ex vivo porcine intestines on a wire rack and put a piece of receipt paper underneath. As soon as the laser has burned through the intestines, this is signaled by the appearance of a brown burn spot on the paper. The gel pretreatment is a submucosal injection of 1 cc of a water-based gel that we made from gelatin. In our results, we looked at the time to perforation against the power of the laser. At 5 watts, none of the intestines perforated, not even at the maximum recorded time of 300 seconds or 5 minutes. However, at 10 watts, the intestines did perforate, but the time to perforation was prolonged by pre-treatment with gel. This was seen at a higher power and was statistically significant. Now at 5 watts, even though none of the intestines perforated macroscopically, there were significant histological differences. In specimens with no gel, there's full thickness thermal injury. In specimens treated with gel, the thermal injury is limited to the mucosa and submucosa, and the intervening layer of gel leaves the muscularis and serosa unaffected. So after spot ablation, we tried to dissect with the flexible CO2 laser. We tried to remove a small square of just the mucosal layer. And then we checked for the integrity of the intestines by placing it under water and inflating it with air to check for bubbles and perforation. And this is a picture of a partially dissected out mucosal square. Mucosal dissection is much cleaner with gel. When we looked at the incidence of perforation where we had done the dissection, 56% of the specimens with no gel were perforated after dissection at 5 watts, and 83% were perforated after dissection at 10 watts. None of the specimens that were treated with gel were perforated after dissection. And then when we looked under the microscope, we had some unexpected findings. 22% of the specimens no gel, the removal of this designated mucosal square was incomplete. And in all the specimens treated with gel, the removal was complete. And this has major implications when we consider the oncologic consequences of residual microscopic disease. Under low and high microscope, we can see that there is residual submucosa and mucosa. And in those specimens treated with gel, the mucosa has been cleanly and completely lifted off. So in conclusion, the flexible CO2 laser is safe at 5 watts, but easily dissects through burns through the intestines at 10 watts. Submucosal injection protects the intestines during ablation and dissection, and gel pretreatment furthermore elevates the mucosa and facilitates its complete removal. So we believe that this is a tool that you can use for ablation and dissection in endoscopic and laparoscopic surgery of the intestines, and pretreatment with a water-based material can protect the intestines as you use this flexible CO2 laser. Thank you.